Thanks once again for having me over on a topic that's very dear to my heart. Current controversies in the management of the neck. It's something that's very huge. There's a lot of work done in the recent past. Very difficult for me to put everything into a half an hour talk. But what I'll do is kind of give you a flavor of what we've done and how the science has evolved in the management of the neck. And I'll be delighted at the end to take any questions that people may have and we can just discuss. So I bring you greetings from the Apollo Hospital. So I used to be at the Tatas for 30 odd years. No prizes now for guessing my age, but just to tell you that I spent most of my career there. I'm now with the Apollo Group. It's the largest private health provider in the country. We've got 72 hospitals in the country and overseas as well. More than 10,000 beds. Oncology is the focus in the coming decade. And all hospitals, or the majority of the major hospitals, are JCI accredited. And in keeping with the chairman's vision, it's to give international standards of healthcare at affordable Indian prices. We are also the first group to have the proton in our part of the world. And I gather that y'all are getting one in Manchester. I'm not sure, or at the Royal Marsden, I'm not sure where, but it's coming, and I'm not sure if it's up and about, but proton is a new form of radiotherapy that doesn't really have the side effects of conventional radiotherapy. Now, coming to my topic per se, for years and decades, the radical neck dissection was the standard treatment for neck nodes. But the last 2 or 3 decades has seen a continuous evolvement as to how we treat the neck. We've migrated from radical to conservative procedures. Non-surgical organ preservation had come in a big way for larynx, oropharynx, and hypopharynx. So surgery basically only became a salvage for the neck. There have been great advances in imaging, the sentinel node biopsy that have impacted on how we manage the neck. But for me, if you ask me, what's the real change in the treatment of the neck? It's really understanding the biology and emergence of new data. And as we go along in my talk, you'll find that these 2 points are very, very important and have really impacted on the way we treat our patients. The neck, as I said, has always been dear to me, and with our group at the Tata Memorial, we've done a whole load of studies on the neck, extent of neck dissection, whether to treat the contralateral neck, need for randomized trials. And really the piece, the resistance of all ours was our elective versus therapeutic neck dissection, where we for the first time conclusively showed that treating the neck in this setting was beneficial. And I will share a little data on that with you all. So cervical metastasis for the youngsters is probably the single most important prognostic factor in head and neck cancer. The moment you have a neck node positive, however small the focus is, it decreases survival by 50%, and you go straight from stage 1 to stage 3. If the disease comes out of the capsule of the node, there's a further 50% reduction in survival. And you straight away go into the N2 category. And it's important to know that even small nodes as small as 5 millimeters and high as a fourth of those nodes could have extracapsular spread. So therefore, regional failures are an important cause of mortality, and appropriate management is paramount. You must get your nodes quickly, and you must get your nodes well. Give that the right treatment, and that way you can secure life and decrease mortality of your patients. And like I said, this was the area that we impacted on, and I'll start with that. The treatment of the elective neck versus a therapeutic option or a wait and watch option for a node negative oral cancer. So the primary, as seen in this photograph, is treated by a per oral excision, debate as to whether you should do a wait and watch, then a therapeutic neck dissection among those that relapse in the neck. Proponents of this theory said that it avoids additional surgical procedures and morbidities and costs in about 70% of cases with no compromise in survival, as opposed to the other group that did the elective neck dissection and said this resulted in better control and survival, and it's a single stage procedure. So we did a very, very simple study, which was a randomized controlled trial where we screened 1,281 early T1, T2 clinico-radiological. And when I say radiological, ultrasound was the factor that we used, the imaging that we used. We randomized 596 patients. At the time of publication, we analyzed 500 because the Data and Safety Monitoring Committee of our hospital uh, kind of observed more happenings in one of the arms and asked us to analyze our data. At that time, we had 243 in the elective neck dissection arm and 253 in the wait and watch arm. So it is very, very simple trial, randomized into elective neck versus wait and watch. Look what happened. In the elective neck dissection arm, there were 181 recurrences. In the wait and watch arm, that's the therapeutic neck, there were 146 recurrences. That translated to a 23.6% difference in the disease-free survival with a hazard ratio of 0.45 and a highly significant p-value. Look what happened to overall survival. There were 50 deaths in the END arm, 79 in the wait and watch or therapeutic neck dissection arm, translating to a 12.5% difference in overall survival with a hazard ratio of 0.64 and again a highly significant p-value of 0.014. If you translate these into numbers to treat, remember it's 23.6% for disease-free, which is close to 25, and here 12.5 between 80 and 67.5 for overall survival. So it translated into numbers to treat that one death is prevented for every 8 patients treated with elective neck dissection, 1 recurrence for every 4 treated with elective neck dissection, and elective neck dissection should therefore be the standard of care for early stage node negative oral cancer, level 1 evidence that it saves lives. Here is another study that came from your part of the world. It was running simultaneously with our study, and Ian, who I've known for years, and I know a number of co-investigators in this authors list, we kind of explored whether we could amalgamate both the databases because our study had so many more numbers, and Ian was very keen that we do it. But as luck would have it, we have to have governmental clearance for that. And also the Data and Safety Monitoring Committee of our hospital stepped in and asked us to analyze our data, and it was statistically significant. Otherwise, maybe I would have been part of this co-author list and we would have had our 500 and these 250 patients. But I'm sure all of you all are familiar with the SEN trial from the UK, 250 patients, T1, T2. They finally added an observational cohort of 346 patients, 27 hospitals. Again, strong benefit of doing elective neck dissection, disease-free survival with a hazard ratio of 0.66. And interestingly, benefit was also seen in small T1 tumors. The inclusion criteria were more or less similar to ours. We went T1, T2 up to 4, and here it was 1 to 3 centimeters, but more or less the same inclusion criteria and the same cohort of patients. Subsequently, 8 meta-analyses on the same issue And if I summarize all these meta-analysis in one slide, it's busy, but I'd ask you all to just focus on the right column, which is the conclusion column. And I've underlined the significant words telling you that the E&D scores over the wait and watch approach in all 8 meta-analysis. And you can see they are all recent. Our publication was 2015. Subsequently, you have 8 meta-analysis. And sometimes I wonder why people waste so much of time when there are 2 randomized trials, which are the highest level of evidence showing benefit of doing the neck. Now that we know we have to do the neck, there have always been questions like, could it be avoided in a certain percentage of patients? And the first thing that people say is, could it be avoided in people with thinner tumors? Here is the forest plot of our study. And as you can see, for both stratification as well as factors that influence outcome in this group of patients, you can see there's a sizable benefit doing the elective neck dissection. But if you focus to the last group, that's depth less than 3 millimeters, you can barely see the box because the number of patients are small, but there seems to be no benefit doing the neck. There were 71 patients. Really, our trial was not answered and was not powered to answer this question. And there were a small number of patients in this group. The thicker the tumor, the more likely that you're going to get metastasis. And for decades, people believed when the probability of neck metastasis was more than 20%, you needed to do the neck because then you would see a difference in mortality. But I put up this classical photograph from Spiro's work, which is also in Jatin Shah's book, that it's not that if you have thin tumors, you're immune to getting neck metastasis. Here is Ron Spiro's work from Sloan Kettering that shows that even if you have a 2 millimeter or less tumor, it's already invaded. There is a probability of neck node metastasis, which could be 7%. The risk of occult metastasis, the incidence of nodal metastasis, 13%, and 3% of patients die. So really, if you have 2 arms in your study, you need the probability more than 20%. But even thinner tumors do have metastasis. And as we go along, you'll see that however thin your tumor is, if you metastasize, the probability of you being salvaged becomes lower. Now, thin tumors is also very difficult to gauge clinically or on radiological imaging. There's really no validated method by which we know how thin or how thick a tumor is. Here is a lovely study looking at the correlation between clinical and MRI assessment for depth of invasion in oral tongue. And this comes out of the Jonathan Iris, Ralph Gilbert group at Princess Margaret. They looked at probably the first study evaluating thickness comparison with radiographic interpretation in oral cavity cancers. They write very clearly that there's strong correlation between path, radio, and clinical for deep tumors. The moment you come to superficial tumors, there's a low correlation. And this is exactly what we saw in our study, something that is waiting to be published, where we bread loafed the tumor, the surgeon on table assessed the thickness, we sent it to the frozen room, and then we sent it to final histopath. The concordance was very good between all 3 for thicker tumors. But if it was very thin, the concordance, the area, the ROC wasn't so accurate. So really interpreting a very thin tumor is difficult and we have no validated method. More importantly, you can pinch a tongue tumor, but 50% of them are painful. But you can't do this thickness for buccal, you can't do it for palate, you can't do it for lip. It's not very accurate. If a patient came to me, operated by a good surgeon, less than 3 millimeters, didn't want to have the neck, I probably would say, fine, we'll observe. But if I'm operating, unless it's really the thinnest of tumors on the mucosa, the patient would have a neck dissection. Second controversy, can image identify occult metastasis? We've been improving in the images, even the CT qualities, high resolution has gone up. The MRI, now you can do diffusion weighted images, there's the PET, there's an ultrasound. Here's a meta-analysis looking at identifying lymph nodes in the N0 setting. And as you can see, the CT has the highest specificity compared to the other modalities, but there was no difference in the sensitivity. And you can see how the sensitivity it is very, very high. Specificity better, but still a lot to be desired. Now, these are numbers, and I'm going to put it a little more practically for me to drive my point home. And before I do that, people now say that the PET scan is probably very good. And this is a new study called the Akron 6685, which was 287 prospectively enrolled patients from 23 American College of Radiology institutions, looking at the PET scan in the N0 setting. So there were 270 N0 necks and 212 participants. The negative predictive value was pretty high, 0.868, when you looked at visual assessment of the scans. But if you tinkered with the SUV value, you can see that the negative predictive value would go higher. And when they use a cutoff of just 1.8, the negative predictive value, which is fairly high, is 0.942. It changed the plan. Clinicians were blinded to the PET report, and then they were informed the PET report. It resulted in a 22% change in treatment plan. The true negatives were 87% and the false negatives were 13%. Now, does this make PET, or is this robust enough to make PET in the N0 setting? My answer is no, because they have not really looked at outcomes of these patients. You can see that the true negatives is just 87%. And 1 in 5, you have a treatment plan change. No one has looked at survival. No one has looked at salvage. No one has looked at the need for more treatment. Suffice to say that we will have better advances with various radiological investigations. But at this point in time, we don't have any in our armamentarium that would be able to diagnose an occult metastasis in an early oral cavity cancer. And like I said, if you look at it in a clinical situation, here is data from 2 people from the Netherlands group that do the wait and watch and the wait and scan approach. Yoon from Hong Kong, who has a randomized trial and followed patients with the ultrasound and also scanned them with the ultrasound before. And the SENT trial, which had 415 patients from 14 centers in Europe doing a CT and MR and supplemented with a US guided FNA when required. And I'm just going to tell you to concentrate on this last box. Among the 415 patients, despite such a rigorous preoperative workup, 23% were SNB positive. So whatever you do your patient CT and or MR, plus minus a US guided FNA, about a fourth of your patients will slip through preoperative imaging and manifest with a sentinel node biopsy. So truly imaging does not help us to identify occult metastasis as of today. The third, could meticulous follow-up help us to avoid neck dissection in our patients? And here are recent ASCO guidelines in March of last year, and I'm a co-author on these guidelines. They say you do the neck for all your patients, but there may be a group that can be, who are highly reliable for follow-up CT1. You may do close surveillance, and they cite the Dutch data where ultrasound is very, very popular as the means by which you can pick up these recurrences very fast and salvage or save these patients. Now, on our trial, we had a second randomization arm where we followed patients with physical examination and ultrasound or just physical examination. We presented it at ASCO. And again, this is something that is awaiting publication. All sonographic examination were done by sonologists, radiologists in a high volume center where they had more than 2 years experience. We do more than 100, 150 in the month. And all clinical examinations were done by senior surgeons on the trial. So the attendings on the staff would do this kind of follow-up. So it was fairly well quality controlled. Now look at the time to nodal relapse. I just want you to focus on the 50th percentile. If you did physical examination and ultrasound, the nodes were picked up earlier than if you only did physical examination alone. And the average duration between follow-up was around 2 months, which is pretty good. And that's what we normally advise for all patients with head and neck cancers, particularly oral cancer. So meticulous follow-up, ultrasound done by experts, as well as clinical examination done by attendings who have fairly good experience in these tumors. Look what happened to overall survival. Absolutely no difference. All patients, both the graphs overlap. Look in the wait and watch arm where it's really supposed to make a difference. Again, absolutely no statistical difference. If you did a physical examination with ultrasound or just a physical examination, the p-value was 0.35. This data is not only seen by us. Here is data from the Sloan Kettering, an old paper followed clinically patients who had the N0 and the wait and watch. 19 of these patients presented with N1. The rest were N2A, N2B, N3. Nearly 50% had ECS. And if you look at bad factors, the majority would have bad factors, which was upwards of 70%. Now, this is in a developed country, meticulous follow-up every 2 to 3 months, yet you have patients with 70% of them with bad factors, either large nodes or ECS. Look at the people who advocate, the Netherlands group and the Hong Kong group that did the ultrasound in follow-up. Focus on the right column here. Look how nodes relapsed. 9 out of 12 had extracapsular spread. 4 died. That's 25% of those that relapsed. 10 out of 12 needed adjuvant treatment. Look what happened in this study. Nearly 90% needed an MRND. 90% needed adjuvant radiotherapy. And exactly in the Hong Kong trial, 8 out of 11 needed an RND, 2 out of 11 an MRND. So you can just understand that when they relapse, they're biologically more aggressive and they come with larger nodes and extracapsular spread. So follow-up again is not good for our patients. Biological aggressiveness trumps the meticulous wait and watch approach and necessitates the need for an elective neck treatment. So we have level 1 evidence from our study, the SEND trial from the UK, 8 meta-analysis. I've shown you data that imaging is not good. Meticulous follow-up has its own limitations. Thickness is something that you're not able to assess, so we must treat the neck. The next controversy is what we should do. Should we do an SNB? Should we do an SOHD? Or should we do an MND? So literature is replete with studies on the SNB. I mean, you just put this word into your Google taskbar and there's just so many things that come, meta-analysis and this, that, large perspective. There have not been any randomized studies. But the one thing we know about SNB is that it has a very high diagnostic accuracy and a negative predictive value that hovers between 90 and 95. So it's a good diagnostic tool to do. So could we just do a sentinel node biopsy and replace big surgery? It's conceptually very, very attractive. Our breast colleagues do it. Our melanoma colleagues do it, but then they have severe edema of the limbs and that's why they do it. Should we do it? Let's see what our data says. 2 randomized trial. This was in ASCO last year, a Japanese trial looking at T1 disease, all patients more than 4 millimeters thick tumor, and SNB was done in 134, a nodal dissection in 137. No difference in 3-year overall survival or relapse-free survival. Absolutely no difference. So it's good. These were trials that were designed or powered on equipoise. 1 and 3 month arm abduction was significantly worse in the neck dissection. No details, as this was only in abstract form and it's not been published till now. So we know they okay, and maybe there's some dysfunction in the arm, but we don't have any details here. This year's ASCO, a French trial looking at T1, T2 oral cancers, oropharyngeal cancers, 2 arms exactly the same, neck dissection or the sentinel node, and followed by neck if the sentinel node is positive. Primary endpoint was neck relapse-free survival at 2 and 5 years, again an equivalence with a delta of 10%. And the functional outcomes were assessed comparing the length of hospital stay, number of physiotherapy prescriptions, and dysfunction in the neck and shoulder scales during the 2-year post-op. Let's see this study. If you look at, there were 307 patients, 10 hospitals, 279 evaluable cases. Neck-free survival at 2 and 5 years, same. So it was within the 10% statistically significant. So it's absolutely the same whether you do a sentinel node or you do a neck dissection. They say that the arm function was statistically worse at the end of the 2nd, 4th, and 6th months, but there was no difference at 12 months. So from both the Japanese and the French study, we know that it's safe to do a sentinel node biopsy. There may be some benefit in the sentinel node in arm abduction and arm function in the first few months. But as you go further out into time, the function is exactly the same. 2 randomized trials, fair number of patients, one from Japan, one from France. We wait to read this when it's in print because then it's peer reviewed, but really telling you these conclusions. Now, how should we then interpret this data in our practice? Given the equivalence, that means both are safe, other factors should drive our decision for a sentinel node biopsy. The learning curve is steep. The costs are much more. The procedure is cumbersome. You have to use a nuclear procedure, a dye, you have to do serial step sectioning, you have to do IHC. It's a 2-step procedure in about 1/4 to 1/3 of patients. And the morbidity is not as high as in the limb, in breast, and in melanoma. Your shoulder function comes back to normal in 12 months. So really, given all these limitations I've highlighted in red, sentinel node biopsy may be done, but it's not popular. And here is data from the Pittsburgh group, published a year or two back, looking at the National Cancer Database in the US, 8,000 odd patients, good follow-up. You can see that though the sentinel node biopsy reduced perioperative morbidity and hospitals say had a similar overall survival, it was not popular in the US. And out of this large database, only 2.9% of the cohort had the sentinel node biopsy. So the message you guys should do is, if you want to do a sentinel node biopsy, you've got a lot of time, it's safe. You may have some benefit in shoulder function, but given the costs and various other things, and everywhere healthcare is trying to cut down costs, it's a question, given that the benefits aren't as much and apparent as in breast and melanoma. So if we don't do the sentinel node, what should be the extent of neck dissection? Bob Byers told us 15.8% skip metastasis. So go do level 4, fish out nodes at level 4. On the left side, you run the risk of hitting the thoracic duct. Some people said don't do 2B because then you won't have shoulder dysfunction. And there was nice prospective data from Lim, Elsheikh, and others. Others said don't touch level 5. It need not be addressed. That's where you really screw up the accessory nerve. So what do we do? What should be the extent of neck? Here is another very simple study we did at the Tata Memorial, led by one of my colleagues, Dr. Gauri Pantvaidya. some of our fellows, Dr. Pai, myself, we looked at 583 neck dissection in 470 treatment-naive oral cancers. 357 were unilateral, 113 bilateral. Nothing fancy about this study. So just like our N0 study, nothing fancy. All we did was put these little tumor bits into small packets and take it and very nicely delineate it with stitches so that we were very accurate in the kind of nodes that we had. Now look at this. We had an equal number of buccal and tongue, a fairly large number. Early, that's T1 to 3 and T4. We had more or less an equal number of node negative, node positive, node negative of 45. The rest were node positive. Look what happened. 96% of our metastases were level 1 to 4, 91% level 1 to 3. Level 2B 3.8, level 4 4.8, and level 5 3.3. There was no skip metastasis at 4 and 5 in the absence of metastasis to level 1 to 3. Skip metastasis at level 3 occurred in 13.8% of the overall. It was highest in tongue, but you would never get 4 and 5 if 1 to 3 was absent. Remember that. Now look at Bob Byers, who said 15.8%. So why is there such a discrepancy? Everybody only remembers the 15.8%. Read Bob Byers' paper. It's from the MD Anderson, head and neck 97. There were barely 3% of his patients with level 4 metastasis. He took 277 patients, removed 7 of them. 12 had level 3 metastasis, which would anyway have been addressed. 2B, which would have been addressed. 11 had level 3 and other levels. And then he did some fancy calculation of adding all these 34 plus 9 who relapsed it at level flow in the absence of radiotherapy and minus it from 7 who were excluded from the analysis. Out of a total of 277, he got 15.8. But truly, if you see, it was only 3%. And Bob Byers' study was over 20 years. It was retrospective data, unlike the packages that we did with more than 550 patients, which is really, really very accurate data. What affects nodes at level 2B and 5? 5 is buccal retromolar trigone with the presence of level 2A and 3, and tongue affects level 2B and in the presence of 2A. So if you have buccal and retromolar with large nodes at level 2 and 3, do your level 5. If you have tongue with nodes at level 2A, please go ahead and do 2B, otherwise save these structures and you won't have accessory dysfunction. Here is prospective data that tells you that this is absolutely fine. SOND versus an MND in the clinically node negative, you can see exactly no differences, fewer complications in the SOND group. So really, that's good enough for our patients. Meta-analysis looking at 5 studies in the node positive setting. 443 patients looking at ipsilateral, contralateral, and overall neck recurrence. And you can see both the disease-specific death rate and the overall death rate p-values do not have any difference. So you can even do an SOHD if you have a node positive, but a decent volume of nodes. And here is a review of literature, a meta-analysis systemic review using the PRISMA guidelines from the Alfio Farlito group, looking that when they reviewed literature, the SND is a valid option in patients with CN1 and select CN2, non-fixed nodes, absence of palpable metastasis at 4 and 5, or the absence of large volume nodes or multiple levels of node positive. So I'm making a point from our data, from a prospective study, from a meta-analysis, and from a PRISMA systemic review, that a supraomoid dissection, you can save your accessory nerve, except when you have large bulky nodes at level 2 or CN2 nodes. But when you operate, your operation must be very meticulous. You must have a minimum of 18 nodes that have to be dissected. And these are in ASCO guidelines, both for the supraomoid as well as the modified neck dissection. depends on whatever levels you do, you must harvest at least 18 nodes. And there are many studies that show the benefit of the more nodes that you harvest, the better the outcomes are. Here is a systematic review, meta-analysis. Actually, it's one of the big works was done by D.V. Vasudev D.V.'s group, which was US institutions looking at a large number of patients, 1,567. This was Abraham. But all these were large number of studies that were done looking at different points of the lymph nodes. But generally, 18 seems to be the figure that most people accept as the amount of nodes that you need to harvest. There's a lot of data because some have done it with quartile arrangements, some have done it in groups of 5, and they say their 16 nodes is more accurate. But suffice to say, you should do a meticulous neck dissection and harvest as much nodes as you want. And here is the forest plot of this meta-analysis showing that if you harvest more nodes, you have better outcomes, survival improves. So there's absolutely no debate in these 7 studies, 6 of them really showing benefit of harvesting more nodes. Node harvest depends on surgeon expertise, the extent of neck dissection, institutional preference. So if you do level 4 and 5 and don't clear 2 and 3 very well, you might get your 18 nodes, but that may not be accurate. So whatever you do, you must do, as well as nodes vary according to the age. Prior radiotherapy, increasing age prior radiotherapy decreases the yield count, the weight of the patient, the T size, the grade, the location. And I've not bored you all with too much of data, but it's all there in this review article that I just cited in my previous slide. But most important is the methods of harvesting the node. So if you're a good surgeon, follow anatomical boundaries, you must rush back to your pathologist if he or she only reports on 6 nodes, 8 nodes, 10 nodes, and have the harvest in the pathology done correctly. And I'm just giving you a recent hot off the press article looking at the pathology protocol in harvesting of nodes. I'm not going to put too much. This is from the Kansas group. But really what they did is the pathologist went ahead and harvested nodes from the specimen, and then they kept the adipose tissue at the side. And then when you minutely went into it, and I'm just simplifying the process, but you all guys can read this article, you can see that you could harvest much more nodes with a relative increase of 30%. And some of these nodes were positive in 4 cases. It really did not change the staging, but harvesting these nodes gives you a lot of important information. And that's another controversy on changing metrics on how you control the neck. The lymph node yield, the lymph node density, number of lymph nodes, and that could be a talk by itself. And these dissected nodes, which were missed, varied in size from 0.34 to 2.23 centimeters. Probably this pathologist didn't do his work too well, because I'm sure even I would have picked this kind of a node up. So in conclusions, it's preferable to treat the N0 neck. Logistically and END preferable, SNB has its place. Level 4, 5 and 2B only when you have large bulky nodes in advanced case. The quality of neck dissection is important and is based on surgical technique and node harvest. But most importantly, and I told you, is understanding biology, and simple studies like ours can help answer seemingly difficult issues. And I'm ending with 2 just, if I can say, stimulatory sites for the residents that are listening in. All our studies that we did were absolutely low budget. You don't need millions to do research. The N0 that we published in the NEJM, it's close to 500 citations when you see it now, was done with about 30,000 US dollars, because both procedures were standard of care. We just needed dedicated trial coordinators and fellows over the years of the study, and we were able to give level 1 evidence that stimulated so many meta-analyses, as well as the SENS study subsequently, to address such an important point. And you can do your study anyway, and I'd urge the residents to read how vitamin C was found in the treatment of scurvy, how James Lind found it on board the ship just using 12 sailors, which he broke up into groups of 2, and he gave 6 different portions, and the ones that ate the lemon was saved of scurvy on long voyages that day. So thanks once again, Ali and Ishan, for inviting me. It's a pleasure. I'll be delighted to take any questions. And like I said in the beginning, there were so many more controversies, and I could have put it, but I tried to focus within the 30, 35, 40 minutes that I had to speak on things that were relevant to the literature that we've done, and something that's very, very burning today in surgical literature. I'll be delighted to take questions. Thank you for your attention.
Prof. De Cruz, many thanks for that. That was really educational, very thorough, and answered a lot of the questions that I had in my mind about the controversies in neck dissection. If I may, I'll ask you, I'll start off with a couple of questions. One of them is, what do you think of the role of elective radiotherapy in the end-node neck versus surgery? I mean, we are surgeons, we like to operate. Well, what are your thoughts about elective radiotherapy?
You see, it's a very good question, that whether the elective radiotherapy, and I don't think anybody would be able to answer this question, and it's very the reason why this will never be answered is very simple. You look at oral cavity. When you have an early oral cavity lesion, T1, T2, surgery and radiotherapy have same outcome results, and there are enough studies to prove this. But surgery, excising a small tongue or excising a small buccal mucosa, is simple, it's fast, it can be repeated, there's no severe functional and cosmetic deformity, as well as you don't need to give radiotherapy to your patients if they are node negative and your margins are free. So really, if you excise the primary and give radiotherapy, you are now using multimodality therapy, surgery plus radiotherapy, when you could have cured this patient only with surgery and kept radiotherapy in reserve, because a percentage of these patients will recur and many of them will get a second primary. And these days you may be able to give re-radiotherapy, but in a large number you are not. And re-radiotherapy comes with a lot of problems. I'd also draw your attention to a study from Peter McCallum in Australia. The first authors, Brennan, June Corey, is part of the group, and they tried to do that. They excised the primary and they gave radiotherapy to the neck. And y'all can just Google this reference and you can see the study was aborted at 25 patients. It really did not make sense giving radiotherapy. So for 2 reasons, because of this study where outcomes were slightly compromised and they had to abort the study, as well as using such a scarce resource for treating the neck, when a quick elective neck dissection avoiding 5 and 2B can give you the same results, I think it's killing a fly with an atom bomb rather than just using a fly swatter.
I love the analogy. My second question, if I may, is I was recently doing a case a couple of weeks ago, and it was clinically and radiologically and not neck preoperatively. During the operation, I noticed some level 2 nodes that were just over the accessory. What would you advise to be to a resident at that point in time where you feel clinically there is disease? And would you just go through tumor to excise it, or do you sacrifice the accessory? What would you say your practice is?
So a functioning nerve, and if you can get an R0 clearance, there is no need for you to sacrifice the nerve. This patient who has extracapsular spread will have post-operative radio stroke chemotherapy. There is absolutely no, but yes, if the nerve is infiltrated, you're not able to get a plane with the nerve and your mass, please don't cut into the tumor and make a hodgepodge of the entire case. So I put it again in terms of numbers. Here we do just so many oral cavity cancers. So at the Tata Memorial on a given day, in all the operating rooms across the institution, conservative estimate, we would do 3 to 5 oral cavity cancers. Now, I would say out of 100, not even 100, 500, we would need to sacrifice the nerve because of invasion in maybe 1 or 2, in less than 1%. And I'm sure there'll be other colleagues of mine from the Tata Hospital who will be part of this webinar, and I'm sure they'll concur with the figures that I give. So really, it's rare, Ali, to have a nerve involvement accessory. But if you have large N3 nodes infiltrating the muscle, the nerve, the vein, they have to come out. You can't leave back residual disease, and you're not going to cut through disease and shave it off the nerve. That's absolutely crimson. So if you have to take it, take the nerve.
Perfect. Thank you very much. That's very comprehensive. So a few questions from the attendees. One on the role of frozen section of nodes during neck dissection. What are your thoughts?
So the role of frozen section on nodes, I mean, we do use nodes, but I've now shown you data from a meta-analysis, PRISMA guidelines, that even if it's node positive, you can do a conservative neck. You don't have to do a modified neck dissection in all your patients. So here's what I tell people, that if you have occult metastases, you don't have to go and prove these occult metastases have disease and then go to 4 and 5. Generally, your visual and surgical skills will tell you that this node is involved, and I would just do a modified neck dissection. But if you work in an institution where frozen section is easily available, it's not going to tire your pathologists who are required for something more important. It's not going to tremendously add to costs. You could use it as, to supplement information that you need to do into a modified neck dissection. But for me, this is a very moot point. I just do all my cases with a standard supraomoid dissection. If the patient is buccal stroke retromolar and has a largish node at level 2, I just raise the lower flap and do 5, trace the accessory all the way down, do 4, and I'm done with the dissection. I don't use frozen. It's not like I'm going to pick up a spot of disease at 2A and then say, hey, go complete the neck type. It's more my surgical assessment and my radiological information before I go into the operating rooms and at the operating table that decides how I'm going to operate it. So if you don't have frozen section, you don't have to feel handicapped, and you can still operate your patients and do an appropriate dissection.
Perfect. Thank you. The next question is from Daniele. Do you believe in compartmental surgery for tongue tumor? For example,
You mean for the primary?
Yes.
Yeah, that's Fossio Chiesia's work out of Italy, showing that the tongue is a compartment, go into the midline traffic, back into circumvallate papillae, basically taking out the entire neurovascular bundle all the way down from the hyoid. So that big chunk of tissue, really that's an overkill for a T1. That group has shown benefit of that kind of surgery, but really I'll do it for a largish T2. That's to remove the sublingual nodes, take out the entire chunk. If there are any skip in transit metastasis in tongue musculature, I would do that. But if it's a nice T1 like the photograph I showed you, where I showed the debate between END and wait and watch, that little picture that anybody can do it, everybody feels it's so easy to lop off that bit of tongue. Really, I won't do a compartmental. Remember, the tongue is such an important part of your body, important for speech, for swallowing, various other things as well. But anyway, you don't want to remove unnecessarily. And no one is shown doing a hemigloss. So let me tell you, when I started my surgical career, we did the hemiglossectomy. And we just believed that the recurrences would be lower. But then as data emerged, doing a nice wide excision with clear margins is as good as a hemigloss. So except for largest tumors, I don't think I would do a compartment. It would be an overkill.
Great, thank you very much. And a question from Ishan: what do you think of the future role of biomarkers in individualizing the treatment of squamous cell carcinoma of the neck?
So again, interesting question. There has been work looking at molecular markers. I draw your attention to a publication from Ropman's group where they have looked at doing these gene expression classifiers. They did it and they validated, then they did a trainer set, and then they did a validation set. And they did show that they could decrease the number of patients who would have the elective, who could go into the elective the wait and watch, and those that needed elective. Now, I don't remember the exact percentage, but they did show that there was some variation, that basically the ones that could be wait and watched would be a higher number. And I'll have the slide somewhere at the bottom of my presentation, but I'll just quote it. It's called Ropman's group, and you can just Google and read that paper. But our group also, one of our young surgeons, Sudhir Nair, who I hired to lead the research on a head and neck service, also did some work on that. He showed MMP and MMP10 and one more biomarker. If they were expressed, then you did have a higher incidence of nodal metastasis. But just look at the practicality. We don't have one definite marker that shows 100% operate or don't operate. Two, what do? You take a punch from the tumor, you'll do the biomarker, and then when do you go back subsequently to operate? How do you know the sampling? Because at some times you might punch at an area which may not be represented. There may be tumor heterogeneity in molecular markers. So there are very many questions. It is an area in evolution. Someday probably we will have a marker that will tell us that yes, these are operated and these aren't. But at this point in time, it's still in research mode. And these 2-3 papers that I've cited to you, you can just Google to complete your knowledge on the subject.
Well, thank you very much. That's very
I
informative.
see an interesting question from Drew. Who's this? Drew Harrington? I can see an HAR written there.
Yes, Drew Harris is here. So
He says slightly off the topic, but not purely oral cavity with the N3 disease. If you're treating the primary with chemo-RT, would you like to do an upfront neck dissection prior to non-surgical treatment, as is common in oropharyngeal HPV? Okay, so Drew, let me tell you, I have a publication and I called it split therapy. And we did it many moons back when we didn't have chemo radiotherapy. And probably at that time, radiotherapy also was not the IMRT mode. It would be cobalt or 2D CRT. And I postulated that plucking out this node in the beginning would help you then give radiotherapy. 2-3 things happen with that. One, if you have an N3 node and you just go to do a node excision, there's also a publication by Bob Byers from the MD Anderson on the same subject. I'm going to tell you what happens. If you do an N3 node, very often you're going to have to resect the vagus, you'll have to resect the jugular vein, you'll have to resect the muscle or the accessory. It's N3, it's more than 6 centimeters. It will have 75% extracapsular spread gross. So you're going to resect. Now imagine having a person who you resected this node, you have the skin flap there, the sternocleidomastoid is gone, you've got a carotid pulsating below your neck, and you have to take him up to 7,000 rads. Not a good idea. Imagine if the vagus went or some other complication happened, you're delaying definitive therapy. You have better modalities now. Chemoradiotherapy, you have the PET scan, which has a negative predictive value upwards of 95%. Why do you want to delay definitive therapy? Why do you want to risk complications in a fourth of patients? And why do you want to then have these patients who will be very difficult to salvage? Imagine you having done a neck dissection and then you have a residual tumor in the larynx. Now here you have a skin flap that's gone and got stuck to your carotid because you have taken out the sternocleidomastoid. How are you going to salvage this patient? So this was a treatment earlier. I think even in the Mehana paper, they did permit people to do it first. But to me, it's now relegated to history. I would do the chemo radiotherapy and then decide what I want to do. The other option of downsizing is using chemotherapy. And you have some studies, the Everett Vokes group, the Paradigm trial, and the Decide trial, looking at N2, N3 setting. And I think there's one from the French group that just come a couple of weeks back. You can just Google and read them, all these. They looked at overall survival in this. Downsizing chemo may be a more attractive option in my book than surgery.
Perfect. That answered kind of my question about the carcinoma unknown primary with the bulky nodal disease. That's kind of along the same
Yep.
process. Perhaps we have time for one last question, if I may, and it is by one of my colleagues. Thoughts on the managing of the contralateral neck in lateral tongue tumor, i.e. the role of imaging or sentinel lymph node, where most studies and treatment focus on ipsilateral neck but report a small number of contralateral relapses.
So when I showed you the collage of the studies that we have done, one of them was on the contralateral neck. And I think the first author is Bikramjit Singh. Again, it's a head and neck publication. Basically, we looked at 270 odd patients. And what we showed that when we had lesions that approach the midline. So the first thing is if your lesion touches the midline or is a T3, T4, the chances of contralateral metastasis are 25 to 40%. And I would always operate the contralateral neck, at least sample it in large T3, T4 primaries that come up to the median raphe and cross the raphe. Straight away, the opposite necks 1 to 3 gets done in my book. Now, what happens when it's just approaching the midline and you're not sure whether to operate the contralateral neck? So of all 270 patients that we operated, if the ipsilateral neck was negative, only one patient had a contralateral neck. Out of 270 odd patients, less than 3%. So it was a very small number of patients that had that problem, 0.3%, because it was 1 out of 270 odd patients. So that's my algorithm. If it's a lesion that's approaching the midline, it's not crossing and it's not T3, T4. If the ipsilateral neck is negative, I'm not in a hurry to do the contralateral. I've also gotten good imaging before surgery. So I know that imaging, though I agree with you that, like I said, for the N0, it's not very accurate to tell us an occult metastasis. But generally, all these patients will also have adjuvant post-operative therapy with these large lesions, maybe chemotherapy, and it will be a bilateral field of radiotherapy. But having said that, there is data now evolving that if you have even slightly bigger than occult metastasis, it's better to fish it out and then give radiotherapy than radiotherapy by itself. And again, to debate on that will be another 5-10 minutes because there's a lot of good data to support that kind of approach. And maybe in the years to come, that will be another consensus that we will have in surgical literature.
That's perfect. Well, thank you, Prof. De Cruz. Very thought-provoking and educational talk, and I've learned a great deal, and I can see from the comments lots of thank yous.